Dr. Ibrahim, we are live.
Okay. Hello, everyone. I think now we have a very good numbers of audience with us. And also we have very eminent professors in ERCP hepatology and endoscopy, one of the pioneer of ERCP in Egypt, Professor Khaled El-Basil. And also this is represent the second webinar of combinations of live cases and at the same time lecture on the same subject, which is very good. These webinars, it is done in Masr Dawli Hospital, transmitted for all of you. I hope you enjoy, and you have with you one of the very eminent professors, Dr. Mustafa and Dr. Hani. And we thank Hikma Company for supporting these medical education programs, which is very good for audience and for us and for everyone to facilitate in this area. And also we thank Boston's for supplying everything for us. So I like to present my dear friend and my colleagues, Professor Khaled El-Basil. He will speak with you with the details to what happened today. Professor Khaled.
Dr. Ibrahim, thank you very much for your presentation. I hope that what we are doing today will be with benefit for all of us. We will discuss some cases that will be carried on by our colleague, Dr. Hani Shihab and Dr. Mustafa Ibrahim Mustafa. And I'm so pleased, I'm so happy to share with you this valuable meeting, hoping that it will be with benefit for all of us. Thank you, Dr. Ibrahim, and let's hope to meet in another webinars next in the future. Thank you very much. I think the case that we will do today, Dr. Hani will show us how to make an ERCP for a case of obstructive jaundice, mostly due to cholangiocarcinoma. I think I have no enough history about the case, but I think it's Klatskin tumor, which means cholangiocarcinoma nearby the hilum, and the patients may need to use double stent, one at the left duct and one at the right duct. This can be done by using either plastic stent if the patient is operable and still there is a chance for surgical interference. If not, so we'll use metallic stent just as the palliative approach to ensure the drainage of the biliary system. So we will show the approach of Dr. Hani Shihab together. And if there's any questions from the audience, we will be happy, either me or my dear colleague, Professor Dr. Ibrahim Mustafa, to answer you and to discuss the technique and the prognosis and the treatment of the cases in the second step after finishing the ERCP.
Hello, everyone. So today we will have two cases. The first case is advanced hilar cholangiocarcinoma, and the second case will be for management of a benign biliary stricture with a novel intraductal metallic stent. The first case is a male patient, 53 years old. He presented with obstructive jaundice and abdominal pain. His labs showed total bilirubin of 7.7, direct bilirubin of 6.18. MRCP showed hilar cholangiocarcinoma and irresectable omental deposits. The patient is for ERCP and stenting. MRCP showed the following lesions.
Dr. Hani. Dr. Hani. Dr. Hani. Dr. Hani. Dr. Hani.
Yes, Dr. Ibrahim.
Yes, please, if it's possible, if you look to the MRCP, which presented by Noran, you find that already it is not a hilar tumors. if you look for the MRCP, the origin of the right duct, it's coming just at the structure's side, as this side. You look
Yes, this is true. So what Hani did also in the before we start, that Hani already cannulated the pancreatic duct first. He put a guide wire in the pancreatic duct, and then he did the double wire technique to be able to cannulate the common bile duct. And then the first guide wire passed to the left system, as you can see. And now he is trying to do exactly what you have said, that to try to cannulate from down from here the right system.
yes,
So-
but
so
what
this
is
is,
what is mean Hani by double guide wire techniques?
okay, can we show the picture of the double gower? Okay. No, it's because this is a case of a hilar tumor. So the common bile duct was really collapsed. It was very thin. So the cannulation was difficult. So we entered in the pancreatic duct several times. So when this happens, I prefer to leave the pancreatic. And then with it in place, I use another guide wire to try to connect. This makes it easier because the pancreatic duct wire makes the CBD more straight and the block entry into the pancreatic duct.
So it's a very safe technique, right?
Yeah, some people don't like it. I'm one of the people who really like this technique. It makes the cannulation much easier. Yeah.
No, it's very good techniques, and it should be used, as you said, for
to avoid the chemical irritations of the pancreatic duct, and then you try by another duct to enter the common bile duct. I'm right. This is just to inform the audience what's the idea of the double technique, double guide wire technique.
Yeah, this is exactly, Dr. Khaled, what Hani did offline before we started. The problem now that, as you can see in the MRCP, the right segment, there is a very long, the tumor itself is really blocking totally the access to the right segment. And we injected contrast from the common bile duct. All the contrast went to the left system, not to the right. We will try, Hani will try, and Salma will try for a couple of more minutes to cannulate the right system, and then we will see. So if it will be impossible, the main objective not to put contrast in the right system, and we cannot go to the guide wire. So what we all know that if we inject contrast and contrast will pass to the right system, we need to pass the guide wire. So we need to drain any contrast to avoid any cholangitis. So till now we are safe. The only segment that had been contrast inside, we have a guide wire inside. Already Hani tried to dilate here. So he's still trying to go.
Problem, this is the case, I think it can be classified according to the MRCP into a business 3 or 4.
I would say
4, actually 4. Yeah. So the important thing, as Mustafa said, you'll notice that I injected contrast only in the left duct. So when the guide wire passed into the left duct, only then I injected, but I do not inject under the stricture. So because now I have a wire in this duct, so it's okay, I will be able to drain it. So yes, it will be easier if I inject contrast under this, and some of the contrast goes into the right system, but it is very dangerous if you cannot drain it.
Yeah, again, this is also, I think this is the important message in this part, that we should not be over enthusiastic. If we cannot cannulate the right system, still we have a good drainage for the left system with an uncovered stent, and the patient will benefit from another tomorrow from a PDD for the right system. So that the importance here is not only to show that we can do anything, but the important message that we show the good treatment strategy. We cannot go to the
Mustafa, I agree 100% with you. The audience should know that the target is the benefit of the patients not to do the procedure. You have to remember that you are doing it as a teamwork. You may need your other specialty in the form of the intervention radiologist, that he can help you to drain the other side of the biliary system if you can't enter it easily. And
this is exactly why, Dr. Khaled, me and Hani, we never work in a place which we don't have an intervention radiologist, because such cases you
Right,
need a
you are.
friend, you need a friend to help you tomorrow if we don't go to the right system.
Right, you are.
And
Right, you are.
I think we will try for a couple of more minutes, and then Hani will start deploying an uncovered stent in the left system if no cannulation to the right system.
Dr. Hani and Dr. Mustafa,
Yes.
you have 3 questions coming now. First one, can you use a spyglass in this case?
Okay, Hani will reply. Hani is better than me in the spyglass. Difficult question, huh?
Yes,
It's coming from Mariam Zaghlul.
yes, theoretically you can, but I think in all cases it will always be difficult, because even with the spyglass, in cases like this with a mass obstructing, it will be very hard to direct to know actually where to point the wire. But yes, it can be tried as a last resort.
There are some publications about and some literature about using the spyglass to guide your guide wire inside the structure. However, as Hani said, I think it's technically very challenging because you need to visualize this tumor and then to cannulate inside the tumor with a guide wire. Still, I think a PTD with a rendezvous technique is also a rendezvous, or even the radiologist could even put the stent from the right system directly. The good thing in this patient that Hani already cannulated the left system, which is more difficult for the radiologist, for the radiologist. So the right system for the intervention radiologist are the easy one. Yes. So I think.
So there is another question coming from audience. In a case like that, can you start by BTC first?
Yes, this is a very important question. I'd like to discuss this because there are many papers in the literature that actually prefer PTD. And I'm actually one of the endoscopists who favor PTD, especially if you have an advanced cholangiocarcinoma. There has been studies that showed better performance of PTD. And usually when I get a patient who has Bismuth 3 or 4, I usually counsel him to start with a PTD. But in some cases, the patient just really doesn't want to have a drain outside, doesn't want to do the PTD. And only in these cases where I tell him, okay, we can start with an attempt of.
But there is another question for both of you, which is very important. I'm trying to reply this very quickly and also very straight. He said these are poor patients. Why to do 2 procedures? Why not to start by BTD, which is more successful?
Yes, it is a very valid point, but the thing is, you have to take into account the patient preferences. We are doing this procedure only for the benefit of the patient and make him live a better life these last few months. So he said, no, I don't want to do any, I don't want to have a tube outside of me. So of course you have to tell him that there's a big chance that you will need an ERCB and a PTD.
No, again the question, if you have a patient like that, you start by BTC or you start by ERCB? So
I will just, this is, again, as Hani said, so I will show this in my slides in a couple of minutes. The ESG guidelines is very clear in this point. So you need to do it in a place that you have both of them. So there is till now, there is no, it's a personal preference which one to start. And for example, he preferred to start by sending this patient to do a PDD. Some other doctors will do the ERCP. However, guideline they showed that you need to just work in a place that you can do both, and this is exactly what we are doing. So,
but what do you start? You start by ERCP first.
Personally, I will start by ERCP. Trying to because again, if the radiology has to drain the both ducts, this patient had to have 2 external drain, one from the right segment and one from the epigastrium. So I think even now with putting a metallic stent in the left system, we have saved the patient to have an external drain from the epigastrium, which is not really a very good quality of life. Still, the plan is tomorrow to do a right side, right segment PPD, and even rendezvous.
Okay. Simple other questions. In high area of COVID, what's the precaution for viral transmissions?
So yes, so I think that this is a very good example, and this is why we are putting a metallic stent here. So my only message in this COVID period, that we should not do procedures that I will not put a plastic stent in this patient and then come after 2 weeks again to change it with another plastic stent. If we can, if the patient can do a procedure which is only one procedure, it's better. This is the plus protection for everyone. As you can see, we are all in the room protected with maximum PPE for everyone. Also for the doctor
can the cameraman come nearer to your faces and to the nurse faces?
Yes, could you? Yes, I zoom in.
Because they like to see how the protections.
So we are 3 of us. We are in complete PPE. With goggles and N95 masks and head cover and disposable gowns and 2 pairs of gloves, each of us.
So very good.
And even we have our anesthesiologist there with the P100 mask and a face shield on the other way. So Dina is already more protected than us even on the other side.
And Mustafa, I never shake hands to do the after you're finished.
So now we are. I will insert a 10 centimeter uncovered metallic stent in the left system. By the way, there are reports that
why uncovered, honey?
Of course, I put it uncovered, especially in all hilar strictures. If you put a covered stent, you have a big chance of blocking the drainage of the other system.
Very good.
So I always prefer putting an uncovered stent. There are some Japanese reports that they use covered stents, but I read these are very few case series, and I'm not sure that we can apply this in general.
Yes, I think the message, Hani, here, if you pass the hilum, you always put an uncovered stent.
Exactly.
So I think this is the message. But again, Hani, why a 10 centimeter? And why not an 8 centimeter one?
Okay, now if we are using plastic stent, it's easy that you can just measure by the wire and take a measurement and use the plastic stent the exact same size. But in metal stents, things are not that exact because there is the idea of the foreshortening of the stent.
We are using a wall stent from Boston Scientific, an uncovered 10 millimeter, 10 centimeter stent. And even we discussed in the morning with Hani, even if we have been able to cannulate the right system, we will put both of them. And the idea that when you put 2 uncovered stents, the main idea that to have the distal part in the papilla on the same level. This is the most important message here, because to be able to, if this patient needs to have cleaning of this stent, or even in couple of months stent in a stent technique, so you need to have access to both stents.
They said that sometimes drainage of the left duct is enough.
Yeah, this is also, I will show it in my presentation, that till date with all the randomized studies, no one showed superior. So if it's bilateral stenting or if it should be a unilateral stenting, so there's some studies, is with unilateral, some other studies say bilateral. The only message which I have learned from last years, that whenever you put a contrast in a segment, you should drain. This is the message. So now we have put a contrast in the left system, so we will drain. But again, unilateral, there is nothing in the literature is superior than others. Even more, we may think that we leave this patient with 1 stent and we follow his bilirubin for 1 week, and to wait a little bit for the PTD, because again, we don't have contrast in the right segment. We are not afraid of cholangitis, and we have good drainage of the left system.
And sometimes when you use, as you said, a covered stent.
Sorry, Dr. Khaled, it's what? Can I have the question again?
There is another question coming, which it's need one word answer. it's not better to put two guide wire in the common bile duct.
It's not bad. No, it's not. We can put two guide wires. Yeah, we can.
Okay.
Yes, we can. Yes, yeah, we can put guide wires, and we can put a stent on one guide wire with another parallel guide wire in, beside.
So you can see here that now, of course, the angulation at the top of the duct makes it difficult. So I'm doing this torquing maneuver. It helps to push the stent in. As you can see on the fluoroscopy, when I move in, it pushes it inside. This helps.
Hani, you like to see the distal end of the stent?
Yes, okay. So now, once I'm here, I can see the distal end of the stent.
But we
The
cannot
whole
see it.
dependence
Cannot
will
see
be
it.
on the endoscopic.
No,
side.
the radiological part.
Here in
Yes,
the radiology, you can see
yes,
the
yes.
distal end.
Yes.
Very good. Very
But
good.
I will
very
depend
good.
now on completely on the
Other one.
endoscopic view.
Yes.
So you can see here now the distal end of the stent, and it's
Yes.
well in place. And I
Okay.
prefer to leave at least about 1 centimeter of it outside the papilla. So
That's
now
right.
we'll start. هو camera can get
Could you
it.
zoom? ممكن تزوم على ايد سلمى. So this is she will show you now how to start opening the stent.
So optimally, she fixes this here in her stomach. So this is fixed, and she moves back a little bit. So you have the system straight to reduce the friction. And together, we will start. She will pull here, and this side is fixed. Okay, so يلا بينا.
يلا بينا.
لا. So
Salma,
I'm
take
pulling.
take care of your stomach, huh?
No, we take care of Salma. Don't worry. We take care of Salma. Okay. So
Now it has to be very important
screen on.
that
Well,
we are
she-
coordinated.
We
So
like to
Salma-
see the post.
And when I tell Salma to stop, she stops. Stop. As you can see, it went inside a little bit. So I'll pull it out again.
Honey,
Yes, right.
Okay,
get the
Salma, go.
X-ray down, please.
X-ray. Okay.
Yes.
So you can
Down,
see the
down.
stent.
Stop in position.
Stop.
It's not important up. You should look down.
So this is a little bit of pressure from Dr. Ibrahim that you need to see down, Hani, and you are seeing up. So you answer. I cannot answer. This is
No pressure at all. But
Look down because
on the fluoroscopy, for me, it's not important at all. What's important is the endoscopic view. We can see here the lower part.
yes, this is the most important thing. You have the
Yes,
endoscopic
okay.
view and the radiological view, so
Yeah.
you can manage everything.
We also
Yeah,
have
let's
the
go.
endoscopic. We have the endoscopic view. You can see the distal part of the stent,
Stop.
and hand is keeping
Yes,
pulling
go.
it because there is the tendency of the stent to go
Stop.
inside.
And opening should be okay, very smooth to ensure that there is no loop inside the common bladder.
Yes.
Go.
Yes.
Right, you are.
Yeah.
We are going now to the release.
Very good.
Okay,
Very
so,
good.
so now I have the stent. Now I will try one thing in 1 minute,
To push,
and you will
put the
understand
guide
now
wires
why I
to the-
put this marker at the side of the patient. I will try to pass a wire through the mesh of this stent
Very good.
to enter also the right duct. This is what is called stent in stent.
Yes, it will be
I will leave Hani to do this for 1 minute, and then we go to prepare the presentation. So you have 1 more minute to do this.
Remember, Hani, that around more than 200 doctors follow you.
Okay.
A lot of
Thank
pressure
you.
then, yeah?
Yes.
So now I have taken out the wire and the stent system completely.
Excellent, Doctor.
So now I will try to go in again with a sphincterotome.
With a guide wire.
And I will try, hopefully, through the mesh of this stent to enter the right duct. It's a very low chance. It's difficult.
But you
we'll
have
give
to
it a
try.
What, Khalid, what you said?
I think you should try this step because they may succeed to enter through the mesh of the stent to enter the right side of the hepatic duct.
Very
He
good.
may. Let's hope so.
So,
Usually,
Professor
if
Khalid,
we'll do
he agreed
a stent
he
inside
agrees
stent,
that we give you 1 minute to go through the mesh to the right side.
Yes.
usually if I will do a stent inside stent technique, usually we use different stents which have a larger caliber of the opening. خشي بالواير. Screen.
It is better to use the sphincterotomes or what?
So you see this stent, it's very good. It has small openings of the mesh, which gives it a good radial force, but it makes it difficult for me to do this stent in stent technique. Difficult to pass the wire inside this mesh. ارجعي ورا خالص.
There is another stent with wide mesh, which one has wide shapes, but I don't think it's one of them. But you have to try. You may succeed.
This Hani said that, which is a good question. If you like to go through the stent, you should know another type of stent, and you are right, Hani, Dr. Professor Khalid, in that. But we'll give him a few minutes. But this is a drainage very good.
Yes.
The left side, and maybe the only we have. I think if you cannot ask, we can ask you some question, and you reply quickly. We can ask you some question.
No.
Hani.
Yes, sir.
I will ask some question and reply very quickly.
Yeah, sure.
What's the position of the patient?
The patient is prone. This is my preference.
Okay.
But it's not a must. Mustafa always works supine. There is no, it depends on your preference.
But for the hilar tumor,
No, I mean,
I always work prone. I'm not sure if you, sir, different preference.
No, I prefer the prone positions normally.
The prone position is better because it avoids the solutions to be covering the patella, the secretions covering the patella. But on the other side, the supine position, keeping the anatomical solutions of the biliary system so clean enough.
There's another question, Hani, what is the number and time of difficult cannulations? Hani?
Yes, sir.
What is the number and time of difficult cannulations?
The number and the time of difficult cannulation?
Yes.
There are published guidelines that they say, for example, 10 minutes or 5 passages of the pancreatic wire. But I think this is mainly for either training purposes or for publication purposes. In real life, with some experience, you get to know when you can actually give it more. There is some hope you can continue more, or that you have to stop. I think, of course, it's very important not to stay too much. I think half an hour is usually more than enough with an expert. If you don't feel it's working, then it's not going to work, because you can do more damage than by persisting to cannulate.
Okay. Hani, we'd like to thank you very much. We have 18 questions, but we will answer all of the audience. We reach up to 210 now. So all the questions will be answered after the lectures, because you may get your answer during the lectures. If not, Professor Khalid, me and Hani and Mustafa will answer. So keep your question until the lectures is finished, and we will see what happens. So thank you, Hani, for this marvelous work and for good drainage, which may be the only way to drain the left duct, which is enough. And now we start by the lecture by Dr. Mustafa about stenting. So now we start the lecture.
Okay, so good afternoon, everyone. So for the next 20 minutes, I will do my best to, it's a difficult task to cover everything about GI stenting. So it's a very practical presentation of GI stenting. So as you know that GI stenting, we have luminal stenting, esophageal, duodenal, colonic, biliary, like what you have seen now for benign lesions, for malignant lesion, and then what's new or what's really up to date. For esophageal stenting, we have for benign stenting, for benign stricture and or malignant palliation or treatment of fistula. So for malignant palliation, it's always the patient who present by dysphagia, and it's very effective in more than 80% with a very also high success rate. We can also put sometimes stents to close a fistula in very advanced cancer, stomach, cancer esophagus, between the trachea and the esophagus. It's always partially covered stent, and because just to avoid migration. Fistulas, and this is what we know and what we see every day. So and it's very nice that I'm presenting today with Hani. We are very good friends, but on the other side we do this treatment of fistula totally different. Hani always use the fully covered stent. I follow what I have learned in Brussels, the stent in stent technique. So when you have a patient with fistula, for example, this is a patient post sleeve gastrectomy where you have fistula, and you can see the fistula here at the junction between the gastroesophageal junction. What I do, my preferred stent is the partially covered stent, and this is not the standard of care here in Egypt. I put a partially covered stent, an ultraflex stent, to cover the fistula part like this. And then the idea here is not only the stent, the water sealing happened because of the hyperplasia, which will happen at the distal part here of the stent, and this is why the stent will stay in place. However, the difficult part and the tricky part is how to remove this stent. So this is why we have to do what we say stent in stent technique. So this is a video of the same patient after of 6 weeks when we put, you can see the ultraflex stent inside with the hyperplasia here. You cannot remove the stent just simply by pulling the stent. The other one, the fully covered stent, the mega stent, you can simply remove it after 6 weeks. But here to remove this, I need to put another stent inside, which is a totally covered stent. So now you can see I'm deploying a fully covered stent inside the stent. And the idea of this second stent is to do necrosis of the hyperplasia, pressure necrosis of the hyperplasia. We leave it for 1 week to do this. You can see this is now the second stent. Previously, I was using more the polyflex, but now I'm using the fully covered wall flex. Then we come back after 1 week and we remove both of them. So first of all, you just with a very simple foreign body biopsy, you start pulling one by one. So you can see here, I'm pulling first of all the first stent. And what I have learned is this: when you need to pull a stent, you need to pull it really very slow and continuous. So, and then after that, you go again, and then you remove, you pull the second stent very slowly. It doesn't matter really to catch it from this loop or not, but you need to catch it from the distal part. And then I will go inside. You can see this patient, we inject contrast and we show that the fistula is closed. Then is this technique, the stent in stent technique, is really effective? Yes, 2 big series have been published. This is the oldest one, the first one where we have a success rate of the removal of 99%. And the very important message here, please, the surgeons should send the patient early to us to be able to put whenever you send the patient early, we have better rate of closure of the fistula. Then for duodenal stent, we have a lot of indication. The most important one of this cancer duodenum or infiltrative cancer pancreas, where you put this stent, duodenal stent, as palliation. There is some also indication for anastomotic stricture where you put a fully covered stent, which rarely I do it. So simply the idea, the duodenal stent is a TTS, which means it's a through the scope stent. You cannulate as you can see on this animation and on the right side in the video, you cannulate the tumor with the guide wire, and then using a therapeutic scope, you go, as you can see here on the right side. And this is, for example, an advanced cancer pancreas where you have biliary obstruction as well as duodenal obstruction. And then I prefer always a long stent. I prefer the 12 centimeter to have it transpyloric to pass the stricture, as well as to have the distal part, as you can see here, transpyloric to be able to stay in position. So this is from the ESGE the recent ESGE guidelines. Whenever you see this patient, the advanced cancer pancreas, you should do both of them. You should drain first of all the bile duct with a biliary self-expandable metallic stent, either partially covered or uncovered. We will discuss this later. And then you should put an uncovered duodenal stent in the same setting after putting the biliary stent. Then also what's new in this area, sometimes you don't need to really to put a duodenal stent. Now with the lamps and with the advances of the EOS, we have the technique of doing gastrojejunostomy by the EOS. So this is one video of the idea. So when you have the gastric outlet obstruction due to cancer and for a palliative treatment, what we do, we first of all, we pass a guide wire and then a nasal and a nasojejunal tube. We fill, as you can see here, we fill the jejunal loops with fluid and contrast and methylene blue, and then we puncture by the EOS this this filled jejunal loop, and then we start deploying the one of the newly stent, the lamps, the hot axis stent, where you anastomote and where you create a new anastomosis, as you can see here, between the stomach and the jejunum. Again, this is a video from my friend Mark Barthé. So again, it's not a daily practice. However, this is one of the future things happening now all over Europe to treat gastric outlet obstruction rather than duodenal stenting. So for colonic stenting, it's mainly for when the patient is occluded by the mass, and this is why it's a palliative also stenting. And sometimes you put the stent as a preoperative just to decompress the colon before the surgeon will go and do the resection. Which stent? Normally we use also the TTS, the through the scope stent. There's some studies about putting an ultraflex in the rectosigmoid. Personally, I prefer always the uncovered stent, the through the scope stent. Going to the biliary part, for the biliary stenting, as you know, we have benign lesions, as you can see, either chronic pancreatitis or iatrogenic or post liver transplantation or post cholecystectomy. And on the other side, we have the malignant, like today, we have the Glaskin tumor, gallbladder cancer, and pancreatic cancer. So this is an example of post cholecystectomy stricture. Another example of liver transplantation. So for liver transplantation, you have two types of strictures, either the very early, the short one, where you have the anastomotic stricture, or the other one where you have the difficult one to, and most probably in the living related patient due to biliary ischemia. And more in Europe, we have the chronic pancreatitis where you have this very tight, very difficult to treat stricture at the lower end of the common bile duct. So how to treat this benign lesion? It's always either plastic stenting or the fully covered stent. So this is all the big paradigm shift happened 10 years ago, when with this stent having a fully covered stent, then you can put it in the bile duct for more than 1 month. Previously, it was more about balloon dilatation. Personally, for the last 10 years, I have never done balloon dilatation for a benign stricture. I always use the plastic stent. But plastic stent here is not only to put one stent, it's to calibrate the stricture. So you need to think about multiple stenting. This is the trial where they started. This is the first trial when had been published almost 7-8 years ago about the fully covered stent, where had the best indication was the post cholecystectomy, and the difficult one was the chronic pancreatitis and the liver transplantation. So ESGE is also clear in this part. It's either or, either to put multiple, and you need to understand this is multiple, because this is the message here. We should not only put one stent and to drain the patient. The idea here is to calibrate the stricture, or to put a fully covered stent. So if we do multiple stenting, we need to put the maximum number of stents, which means I will put 2 and then the patient to come again after 3 months to be 3, to be 4, to be 5, and then till the calibration happen after 12 months, or we can put a fully covered stent for a period of 6 months. Then regarding malignant stricture, we have either like today, like the patient we have just showed, the hilar stricture, or we have the distal stricture of most commonly the cancer pancreas. So for the hilar stricture is either like today, the cholangiocarcinoma, Glaskin tumor, or sometimes extensions from gallbladder or from HSCC or from metastatic lymph node. This is the classification of the Bismuth classification, and I think this is our patient for today. We have this patient. So this is the Bismuth 4, where you have the mass affecting both systems at the bifurcation. So as I said in the live case, this is the most important word, that when you start draining hilar stricture, you need to be ready with everyone. So a good endoscopist and also a radiology department ready to support anytime. So this is why a multidisciplinary team is very important. As I said also in the live case, so for ERCP, ESGE is clear. In Bismuth 1 and 2, we go for ERCP first. And for Bismuth 3 and 4, we have a combination of PTD and ERCP. So what Hani did today is really exactly the guidelines. So we have a combination of ERCP and PTD for this lesion. So number of stent, the question that Professor Ibrahim asked us, should we put only one stent or we should put multiple stent? This is the question had been raised from 25 years ago. Until now, as I said, there's some studies showing multiple is better, other studies showing that unilateral is enough. But as I said in the live case, we should always think about whenever you have contrast in a segment, you should drain it. So this is example of a hilar tumor where we have been able. This is also answering the question of one of our colleagues or our friends here to put 2 guide wires. So in this patient, I have put 2 guide wires, one on the right system, one on the left system, and then I have the guide wire. This is kept in position. I put the stent first on the left system, and I continue, and then you can see this, and then I will go cannulate the second guide wire with the second stent, and this is optimally to be done in hilar tumors. And then I will start opening. And the important message when you start doing this is this picture, is this last picture, to have the 2 stents distally in the papilla in the same position. You can see here and here, you have both opening of both stents to be able to cannulate them if needed. Regarding distal strictures, they are more of in cancer pancreas. This is the most common cause of distal stricture. So treating these strictures with self-expandable metallic stent had been always the gold standard. Then the question had been raised by the Rotterdam group in 2010 when they published the New England Journal of Medicine article on resectable tumor. So previously we learned that, okay, we have a patient and this patient is resectable, put a stent and then send it to surgery. But they changed this. So this is they showed that if there is no difference in this randomized study between putting a stent or not putting a stent. However, the question, this study opened a lot of questions. Is it easy for us in Egypt, especially in the Middle East, to have a surgeon ready to resect the patient as soon as possible, early, like in Netherlands? So again, this is another study is ongoing now in Europe to confirm this data that in resectable tumor, we should not drain and we should send the patient direct to surgery. So ESGE is clear in this part that ESGE recommends against preoperative assessment, preoperative drainage in operable cancer pancreas unless there is very severe cholangitis. So, which is again, this is not the standard of care here in Egypt. So we drain most of the patients. So, however, this is very clear in the guidelines. On the other side, when the patient is indicated for drainage, we should put a self-expandable metallic stent 10 millimeter one to drain the distal stricture. So which stent, again, for this, for non-resectable tumor, should we put a partially covered or we should put an uncovered stent? This had been studied a lot of the literature with no really difference. What I use daily is the partially covered stent, never covered stent, but a partially covered one. So again, this is clear that ESGE recommends self-expandable metallic stent for palliation of this non-resectable tumors. This is another example of a video when you have a distal stricture. So same scenario, you start. The question will open. This patient had a gallbladder. If there's any contraindication to put a partially covered stent in this patient, the answer in the literature is no. So a lot of patients, we have seen a lot of patients. This is why there's some doctors have the tendency to put an uncovered stent. However, there is no clear indication that you should put an uncovered stent. So just for the last few minutes, what's also new about EOS biliary drainage? This had been studied a lot in the last 15 years. When we fail to drain the biliary system by ERCP, it would have been always before the PTD. However, nowadays we can also think about EOS. So it depends. You have two main techniques: either to drain, which is either from the stomach, the EOS hepaticogastrostomy, or from the duodenum, the EOS biliary drainage, EOS-BD, or on the other side, the EOS rendezvous, where the papilla is accessible. However, you cannot do the deep cannulation. So this is an example of a transhepatic rendezvous. You have a segment, you puncture from the liver, from the left system, you inject contrast, and then you have a very good nurse to pass the guide wire from the left system to the common bile duct, and then you go by the scope out, you go another by the ERCP scope, catch the guide wire, and put the stent. So this is the typical EOS transhepatic rendezvous. Another easier one is to do it from the duodenum. You have from the duodenum, the common bile duct is very now. This is an old video where we do what I do in my in the practice. When I fail for the ARCP, I will go here, I will puncture the common bile duct, and if the nurse is capable to pass the guide wire through the duodenum, it's okay. I will put the stent transpapillary. If not, I will do the biliary drainage directly with the EOS, putting the stent in the first part of the duodenum. And then we have the very difficult to do, very advanced technique, the EOS hepaticogastrostomy, where you drain mainly the left system with EOS through the stomach. So this is the same scenario. We puncture from the left lobe. We put the guide wire. It doesn't need really to pass the duodenum, to pass the papilla. And then this is also an older video from Marseille, where we put the stent in stent technique. We put the first stent as an uncovered stent to avoid any compression on other segment, and then on the other side we put a fully covered stent to avoid biliary peritonitis. Then also the new stent, the luminal apposition stent, there had been indicated in a lot of things. One of them is biliary obstruction, and this is a recent study published in Gut 2 years ago about using the Axios, doing this drainage of the bile duct in the duodenum. So this is another video where you have the dilated bile duct from the duodenum, and then with a one step technique, we puncture, we inject contrast to be sure that we are in the duodenum, and then we release the Axios in the first part of the duodenum to palliatively treat this patient. Pseudocyst, I will not go into details, and then also word of necrosis. This is another good indication either for plastic stenting or for metallic stenting. This is a video for, I will say, the standard of care before the lamps, where we puncture the pseudocyst, we duplicate the guide wire, and then we finish the technique by putting a multiple pigtail stents. Again, using the lamps in this scenario had been investigated a lot, especially the hot Axios. So this is one of them. You have a very big collection where we can do this one-step technique, puncturing by the hot Axios, releasing, and having the wide bore drainage of this fluid collection, or of this complicated pseudocyst. The only good thing of putting a lamps in a ward of necrosis that you are able to go inside and to do necrosectomy, where you can go by a gastroscope inside the stent and then clean all this necrotic material. This is the main privilege of having a wide bore drainage. Also, gallbladder drainage for patient, inoperable patient on very risky patient had been already also tested and published. So this is a very thick gallbladder, inflamed gallbladder, where the patient is not fit for surgery. Also, we can use this stents in drainage of the gallbladder. So to sum up my biliary part, if you have a benign biliary stricture, post cholecystectomy or chronic pancreatitis, you think about multiple plastic stenting or a fully covered stent. On the other side, if you have a post liver transplantation in Egypt, a living related patient, you always do a multiple stenting. If it's a cadaveric, you have the choice to do one of the either multiple plastic or a fully covered stent. In malignant biliary stricture, if it's Hyler, as Hani did today, you can put a single uncovered stent. However, we should think about this tumor growth inside, or you could do the multiple uncovered if it's Hani was trying to do this stent in stent technique, and there is the side by side where you can cannulate both ducts and stent like exactly that you go through the first stent to cannulate the other one. In distal stricture in cancer pancreas, you have either to put an uncovered stent with the risk of tumor growth, or to put a partially covered stent with the risk of migration and the theoretical risk of cystic duct covering. Also, to conclude, there is a lot of things now we can do by the new lamps, either drainage of fluid necrosis, wall of necrosis, pancreatic pseudocyst, and also biliary drainage, gallbladder drainage, and the future of gastrojejunostomy. So I would like to thank you very much for this, and I think now we will go. Nuran told me we should go to Professor Ibrahim and Professor Khalid to answer the questions of you. Thank you very much.
Thank you, Dr. Mustafa, for your presentation. It was comprehensive, and I think it raised many questions and many comments from the audience. And me and Dr. Mustafa were ready to receive and answer as much as we can your questions and your comments.
I think Dr. Ibrahim, you have your mic. Your mic is yes. We can
Any role for chemotherapy before ERCP, Dr. Khalid? Dr. Khalid? Normally, there is no role of chemotherapy before ERCP because this is a cholangiocarcinoma. It can be happen, which is called because the bilirubin is very high. It's
the first step is to keep the drainage of the biliary system, and then with the multidisciplinary approach, with the chemotherapy, with the surgeon, we have to discuss what's the next step. But I don't believe that there is a rule of the chemotherapy or the radiotherapy before doing the drainage, either by DMCB, by the BT, or by US.
Okay, another question. Change to Olympus guide wire may be helpful?
As Mustafa said, you have to do this invasive maneuver, ERCP or BTD, in a center where you have different type of guide wires, different type of accessories, because you may like to try different types of wires, because there is different specifications for the guide wire. Some is very thin, as we said, as we know that there is small guide wires with a small diameter, 0.25 French, and there is another larger one, 35. So you have to have different types of size and types of guide wire. There was another one that we used before, as you know, Dr. Ibrahim, known as Tiromo guide wire. It's a slippery guide wire, little bit stiff from the middle and slippery from the distal part of it, and it can navigate easily through these frictions. But there is no specific wire is advisable. You have to have different types of wire with different type of diameter.
Okay. they said that you should apply plastic stent on the left duct so you can facilitate the percutaneous approach.
You have to use plastic on the left side.
Yeah, they asked Harry to put a plastic stent to facilitate a percutaneous approach after that. What's your answer?
I don't have any idea about that approach.
Yani, instead of Hani putting a plastic stent, he can put a plastic stent, not metallic. This to facilitate percutaneous after that.
No, I don't agree with that, because as Dr. Hani used, when you use uncovered metallic stent in a one branch, if the stent
Yes, Hani? Yes, Khalid? So as Khalid said that, no, you can use a metallic, it was not helpful on that. There is some questions which it can be done for Hani, histological examinations of the tumor with piets or with biopsy or anything before for histological. You are with us, Khalid? Yes, I think these questions is important. I think the breast cytology and the biopsy may be needed before putting a stent if the patients it is suspected to have a chemotherapy. Histological examinations, either by taking a biopsy or flushings before procedures.
Okay.
What's your opinion?
Yes, Dr. Brahim, again.
Histological assessment by biopsy or by brush cytology before putting the stent.
It's advisable.
So Khaled said it's advisable to do that. There is another one which is the same. Do you have brushing before or not? I think Khaled said it's advisable to get it. Probably 8 centimeter stent will be the job. Yes, the same question about histology also, which is very good.
Despite
What? So there are many questions about pathology, and maybe when we return to Hani, because this is to him, why don't pathology? Another one from Abdullah, which is better to try to inside the stent, but not through the stent. Besides, the stent is very difficult, especially if you don't put a guide wire before. It's not better to try the stent, but through the stent, yes. Can you use a balloon if you want to get through the stent? There is said that if you like to go through the stent, you can put a balloon, not a sphincterotomes. Maybe you are right, because I'm afraid sometimes the sphincterotomes cannot be get again from the metallic stent. Why not a small guide wire, which is 0.118? Yes, you are right, Dr. Faisal, about that. Why not double techniques, coordination, and not put the same side by side? Why do not double wire, right and left system cannulation, and then put two same side by side? It's very difficult. He cannot go to the right side at all. Any different drainage power if the stent and dry duct or not? It's different in drainage. As Mustafa said, it can be right, left side. It may be enough. There are many studies about that. So I cannot answer that, but there is many studies that drainage of duct in a very poor patient, it may be enough. US guided drainage, very good question. I think it's answered on the lectures. Do you do pre-dilatation when you stent higher a tumor? Already Hani did dilatations. In gastric obstruction or benign esophageal structure, you prefer stenting, do you prefer, this is to Mustafa, in benign gastric outlet obstruction or benign esophageal structure, do you prefer stenting over dilatations or not? Do you prefer stenting or dilatations or not? I think dilatations is first before stenting. This is, I think, the idea is to make dilatations. Now, I try to go quickly. How long you can leave the stent in the biliary drainage? Metallic stent forever. Plastic stent 3 to 6 months, but 3 months is better. Still, Khaled, you are okay with us?
Yes, I am.
Okay, you can. Okay, they said there. They said to us, fix the sound, please. Okay, thank you. We will fix the sound. There is some speaking about that.
Okay.
They said, Khaled, in duodenal structure.
Yes.
And low down malignant structure. Why US drainage or duodenal stent? What you prefer, duodenal stent or US drainage?
Duodenal stent, it's better because we are trying to normalize the quality of the life of the patients. But there is a comment here, before you are putting a duodenal stent, you have to be sure that, as Mustafa said, that the biliary system is already open, because if there is any suspicion of obstruction of the biliary system, you have to ensure that you put a stent in the common bile duct before putting the duodenal stent. Because when you use the duodenal stent only, and then the patients live for a long time up to the lesions may cause biliary obstruction, you are not able to go through that stent to put another stent in the biliary system. So if there is any indications for the duodenal stent, you have to be sure that there is no biliary stricture or biliary obstruction.
Okay, second one, you prefer to put a double pigtail stent inside the uncovered metallic stent to prevent the migrations?
For the biliary system?
Yes, when Hani put a stent, you
Yes.
prefer to make a pigtail so to prevent the uncovered migrating stent to migrate, metallic stent to migrate?
If the patient's got the obstruction due to malignancy, it's better to use the metallic stent rather than the pigtail stent.
He asked after putting the metallic stent,
yes,
he put inside it a double pigtail to prevent the migration of the covered metallic stent.
Of the covered metallic stent.
Uncovered or covered?
If there is another obstruction inside the metallic stent, you can either use.
He answered that. After he finished,
yes,
sometimes people prefer to put a double, a pigtail stent to prevent migration.
To my way, I don't prefer that.
You don't prefer that?
Yes. Yes.
What's the size of metallic stent you prefer for obstruction pancreatic head?
For obstruction?
Pancreatic.
It's just only plastic stent, not more than 5 to 6 French. You're just keeping the drainage of the biliary system, of the pancreatic system.
Also, there's
sometimes, Dr. Ibrahim, if it's the pancreatic duct is hugely dilated, in some cases like the obstruction from malignancy or pseudomyosinous pancreatic cyst, we may use 7 French plastic stent, pigtail.
Yes, there is one, he don't write his name, but he speak about stent on a stent and technique of both the sleeve leakage.
Yes.
The techniques, yeah.
He put stent in a stent, just trying to yes, I know.
Yes.
The stent in a stent technique is used when you can't remove the original first stent after closing of the fistula. You have to try to put stent in the stent, just trying to cause necrosis of the granulation tissue that will prevent the extraction of the old one. And then after 1 to 2 weeks, we have to move both stents together.
Well, should this patient drain by BTC on the day to risk of cholangitis?
The malignant obstruction jaundice?
These patients.
That patient?
BTC
No.
today?
No. I do prefer first to try the ERCP because it's less traumatizing to the liver. If you didn't succeed by the ERCP, you can use the BTC or the BTD.
Yeah, but
because as we know, the BTD, because you know the BTD and the BTC is it's done through the liver, so it's traumatizing to the liver, and we have to avoid trauma to the liver as much as we can.
Okay, but there is they ask about that. They ask about that. The question.
If you didn't succeed in doing RCB.
No, about this case. About this case. You should do in this case the drainage today BTC or not?
No. You have to wait for a couple of days, and you have to be sure that the already stent that had been fixed by Dr. Hani may expand enough and to drain the right side. If it is not, you can go to the BTD.
And also, Hani don't inject at all.
Yes, and he didn't
right
inject
side.
any dye at the right side. Yes.
There is how to measure length of the stent, centimeter, flushing. I look for another question, stenting, extra presentations, which is very good. Please fix the problem with audio. Audio is good, noise is fixed now. No video seen now. So I think we answers all the question except one, which is regard leakage post-sleep gastrotomy. What is the upper level in the upper end of the esophagus and the lower end?
I see.
I don't work in post-sleep.
Yes, actually, I have a good experience about the post-sleep fistula. Sometimes we may use what we call the mega stent. It's a large stent with the caliber of diameter may reach to 28 millimeters, and the flare of it may reach to 36. The length of that stent is variable. It may be 22 centimeters length, and it may be 70 centimeter length. The upper part should be not above the upper esophageal sphincter.
Okay, maybe also we can ask Hani and Mustafa, which is working too much on that. You know, thank you, Professor Khalid, for excellent answering and comment on this one. And then we will go to the Noran now to present the second case. Noran. You are ready, Noran?
هاخد
Hani? Thank you.
عايز تعليق إضاءة عندي شوية؟
So the second case, a female patient, 30 years old. In December 2018, laparoscopic cholecystectomy was done, and it was complicated, so they proceeded to open cholecystectomy. From Jan to April 2019, the patient presented with recurrent hepatic abscess and jaundice. In May 2019, the patient was referred to our center with septic shock. Surgical drainage of the large hepatic abscesses was done, and the patient was admitted to the ICU. In June 2019, PTD was inserted, common hepatic duct stricture with dilated intrahepatic duct, and insertion was done of internal external drain. This is the picture of the PTD that was done in June 2019. And this is the picture of ERCP, 6 centimeter intraductal fully covered metallic stent was inserted in the upper edge of the right hepatic duct. 10 centimeter 7 French plastic stent was inserted in the left hepatic duct to avoid obstruction of the metallic stent that is inserted here. So now we will go to the case.
Yes, Hani.
Okay, so I think now you have the image on the screen. This is
Yes, Hani, we are with you now, Hani. Hani? Yeah, Hani.
Yes, I think, yes.
Yes, we
You
are
can
with
hear
you
us?
now. Yes, yes.
Okay. You can hear Hani?
Yeah, I can hear you.
Can you hear me?
But I was hearing Hani before.
1 second.
Now you can hear me?
Okay, yes? Huh?
Okay.
Yes, Hani.
Okay, so now you have the image of the fluoroscopy. This is from the last case. This is I wanted to show you, this was the double guide wire technique that I used for cannulation. So as you can see, we have the guide wire. It entered several times, so I just leave it there, and then over it, you go outside, you get another sphincterotome or a catheter, and use the guide wire to direct it in the direction of the bile duct. So
We don't have the X-ray. We don't have the X-ray.
Okay, could you show, okay, we will show the X-ray. 1 second.
Yes, yes, very good.
Okay. Yes, you can see. Yes, you can see the X-ray now. This is the X-ray of the last patient,
Yes.
where Hani did the double. You can explain Hani the double duct again.
Right. What are the pancreatic duct?
So it's two guide wires, one in the pancreas
Another common bile duct.
and one common bile duct.
All right, so this is my, she a lot. She had this major post-cholecystectomy complication. This
X-ray, please.
Hani, can you?
Yes.
Hani,
yes.
can you show us what is the endoscopic picture? What is this?
Okay. You show us. Could you show the endoscopic picture, please?
What is it coming from the common bile duct?
So now we have in this patient, what I did was the following, because she had a benign stricture occupying the common hepatic duct. It was very close to the bifurcation. So what I put was there's a specific fully covered metallic stent. It's called the CAFE stent. Now this stent, it's very short. It's 4 to 6 centimeter. It lies completely inside the duct. So I put it, as you can see here on the fluoroscopic image, I dilated the stricture and put it inside. But of course, one part of it entered into the right duct, so it was blocking the other part. So this is why when I do this, I put simultaneously a 7 French stent that goes into the left duct to make sure that the metallic stent didn't block both sides.
Yeah, but this, I have a question for you, because now you can see the 7 French is a little bit, I think, 1 centimeter maybe proximal to the metallic one. Yeah. You think that this makes change, really a change for draining the other segment?
Yes, because now actually this image on the fluoroscopy, it's just overlapping. But actually, the metallic stent is going a bit into the right hepatic duct, and the left stent is going into the plastic stent into the left duct. Okay. So what you can see here coming outside is, of course, the 7 French stent, the plastic stent, and this is the specific lasso that is connected to the metallic stent that's completely inside. Now, of course, the question.
Hani, can you give me a large picture of the video?
Okay, next room, could we have a bigger endoscopic view?
Yes, yes, very good.
Yes,
very
yes,
good.
it's good. Yes.
Okay, so the question is, why did I put a completely introductive stent? Why just not a fully covered stent that comes outside? Well, there is still no proof for this, but supposedly, if the metallic stent is completely inside, it will reduce the rate of migration because it is not exposed to the peristalsis of duodenum, and it will also reduce the reflux.
Hani, your sound is interrupted, Hani.
Okay, 1 second.
Try to fix the microphone.
I will give you. Continue. I will hold it for you.
Okay, can you hear me now?
Yes, very good now.
Okay, so what I was saying, the question is, why do we use an intraductal metallic stent? Why not just a conventional metallic stent going outside of the duodenum? Is that the theory is that when the stent is completely inside the duct, there is less risk of migration. It is less exposed to the duodenal peristalsis. And it will also reduce the probability of duodenobbiliary reflux. And thus, you will have less chance of having sludge and stone formation inside. So we are actually performing a randomized study comparing this to plastic stents currently. We still don't have the full results, but I can tell you they are very promising. So this patient, she had both these stents inside for about 10 months now. She was doing well, and now we will take the stents out.
Okay, so you start by the plastic one, I think. Huh?
What is the instance? What is the instance you cannot remove the stent?
Well, so far, we didn't have any problem in removing these stents.
Inshallah, today also we have no problems.
Yeah, hopefully.
Inshallah.
Okay. Okay. So we'll start by the plastic stent.
Okay, so we will remove first the plastic stent. So you use we will use for this one RAT2 forceps.
Why to use the plastic stent first, not the second one?
There is no rule to it, but I feel it will be easier to get the plastic stent first. And actually, we can actually extract both at the same time, but I try to make it simpler by.
No, I think we take the 7 French inside the scope first, and then we take the other one, because the other one you need to go out with the scope itself.
What is the most good? You use a forceps, balloon, as the basket or snare?
Snare.
So okay, so Professor Khaled said snare. I know Professor Ibrahim always use a basket. I don't know Hani, but personally I start always by a big one like this, and then if I fail in a couple of minutes, I will shift to snare. But I don't know what you do, Hani, normally for stenting.
Depends. I mean, if it is easy to grasp by a snare, I will catch it by a snare. If not, then usually a forceps.
But now you will try to take it inside, because this is also another important message. When you have a 7 French stent, it's easy to go through the working channel. The only technical tip that you do a little bit of left on the small wheel to be able to be. So already this you can see it's because it's already broken. So Hani will go again to take it again. But if you have a 10 French stent, I prefer to take the scope out. I pull it with the scope, holding the tip of the tool by my fingers on the scope, and then pulling the scope itself.
Professor Khaled, how you remove the stent?
Actually, I prefer to use the snare. If I succeed, well and good. If not, I can use the basket. If I succeed, well and good. If I didn't succeed, I use the rat tooth. But I have to be sure that the stent is still capable to be catched fully, because sometimes when you leave the plastic stent for a long time and the patient forgot to return back to his doctor to remove it, the stent will be very friable and will be detached in a pieces, like Hani show us now. There is another way to remove the stent by using the balloon. If you put a balloon inside the balloon extractor, the stone balloon extractor inside the common bile duct or inside the stent, and then inflate the balloon, and then get out the balloon. This is will take the stent outside for enough distance in the lumen of the common in the duodenum.
On زي ما انت.
And by the way, Dr. Ibrahim, I don't prefer to remove the stent inside the channel of the scope, because this may cause damage to the rubber tube in the scope. I do prefer to get the scope out.
So Hani changed it now. He pulled the 7 French stent and the scope outside, and then he will go again to pull the metallic stent.
By the way,
Professor Khaled, if it's a 7 French stent, why you are afraid about pulling back inside the scope?
Just to keep sure that there is no trauma to the rubber tube inside the channel of the scope itself. Because when you are going easier to reach the papilla, so you can get out by the stent and you can get out by the scope itself, and then you can return back easily to reach the papilla. This is to maintain the scope work perfectly and to avoid any internal leakage inside the scope.
Okay. So now, Hani, you will go for the metallic one. You will catch this.
What is the
lasso.
plastic stent? What is the plastic stent?
It's already out.
have removed
We have
He
removed
removed
it,
it.
and there is a small, only the small broken part, which is still in the duodenum. But now we will go for the metallic one. So open.
By the way, Mustafa, did you see the lasso of the distal part of the metallic stent?
Yeah. Yes.
Is it
moved.
clear?
It's screen on. So we catch it now, and then Hani will start pulling. You can fix on his left side here. So it's very important when you start pulling anything to fix this part. So when he will start pulling the scope, he will.
I first prefer when I do with the stent, pull the lasso very close, almost completely inside the
Hani, your voice is not so good.
Okay, like this.
Can you hear me now?
Yes.
Yes.
Better
Is
now.
it good now?
Yes.
Hani, by the way, Dr. Hani,
Yes.
by the way, I do prefer sometimes before removing the metallic stent to wash and make turbulence of the inside of the stent and inside of the common bile duct by saline solution. This may help to remove the debris and the tissues that may interfere with the removing the stent easily.
Okay. So yeah, right now I have pulled the lasso very much inside. Screen.
Okay.
So you see now I'm very close. I'm getting the stent closer to the.
I think not only
Edge
closer,
of the
but you are closing the distal.
And it allows, yes, that the
yeah.
distal end of the stent collapses. Now, if you look at the screen, you will see that the distal end is slightly collapsing.
You can get it out by the balloon.
And now you can see I am just turning my endoscope to the right. You see now the
Yes.
distal edge is getting very tight.
Yes.
So I'm unblocking
everything.
Okay, I don't want to do trauma to the duodenum. And I'll start pulling.
Screen on. Screen.
If you can look on the screen.
Yes, it's going out with you. Very nice.
There is still some resistance. I do some torquing.
Very gently.
And very gently, and there it came out.
Okay. Yes, it's very nice.
Now I'm not sure if you can see our image now. So this is the stent.
Could you show Mixer? Could you show the camera? Yes.
Camera,
Yes.
come nearer, more. Put the stent on your gown.
I'll just put it out.
Yes. Can you see it now?
Yes, it's clear. It's a good job.
Okay.
It's a good job. Excellent.
Okay. So, Hani, what's the next step? You make sure you clean the common bile duct and you make sure there is no more residual.
Yeah, so we just want to make sure, yeah. Of course, usually with these stents, for a long time, you always find debris and maybe some stones. So you need to go in, do a good cholangiogram.
So after this, normally you cannulate now with a balloon directly or with a sphincterotome?
Let's go with a balloon because it helps us do an occlusion cholangiogram, which is very important in this case.
Yes.
To really confirm that there is no residual stricture.
But Hani, I do prefer to make a wash of the common bile duct before injecting contrast by saline to avoid any debris to go inside the intrahepatic radicals. To be sure that there is no debris or no small stones or granules.
Normally,
goes up.
Exactly what I do, Dr. Khalid. I cannulate. I remove the guide wire because the working channel of the guide wire is bigger than the working channel of the contrast inside the balloon. And then I will wash by saline, clean everything.
Yes, that's right.
And then I start injecting contrast.
Yes,
first of all, without I inject contrast first of all without the balloon inflated.
Yes.
And then I start gently inflating the balloon and pulling back the.
That's right. That's what I said. That's right. That's right. That's right.
Yeah.
Screen.
عايز ايه؟ Screen.
ممكن نشيل بتاع الضغط.
ده مش ضغط، ده حاجة هنا.
سكرين.
سكرين. دي حاجة هنا
تحتها. دكتورة الخرطوم بتاع الضغط، قياس الضغط هو معدي تحتها.
لا استنى طيب.
ما هو رايح فين؟ هنا؟
ماشي طيب. حاجة عندها هي. ممكن تبتدي وش كده واحاول اشيلها لك.
Screen. So now you see I'm going deep inside, just as Dr. Khalid said, I don't want to start injecting from below. So now يلا we start to inject some contrast please.
حاول اشيلها.
ما عرفناش الحاجه دي.
نشوف استاذ.
اوكي اوكي.
لا انا ماسكها خالص. ماشي كده. هي حاجه من عندك انت تكابله من الناحيه الثانيه.
اوكي.
inject control يس. screen on.
ممكن نثبت الجهاز كده.
ماشي.
inject.
on screen. كمان.
Excellent.
So Hani, still you don't inflate the balloon now. You go slowly down, and then you start inflating afterwards.
نحتاج كميات كبيرة.
صبغة رمضان كتير.
It's delineate the barrier system clearly. It's a very nice job. Okay. You are going the common bile duct. Okay. It's nice.
انتهي مرونة.
The right and left are clear.
Now what I will do, ممكن ننفخ البالونة هنا من فضلك.
So Hani will inflate the balloon here, and then we will go down.
Now one thing you have to bear in mind, especially when you have these benign strictures, that after some time the CBD shortens very much due to the fibrosis.
Yes.
So you should expect a very short CBD. Screen.
انزل عند المنظار تحت شوية.
نفخ البالونة.
So it is a very nice demonstrations, very nice team, and new technology. Either the first case, or the second case, or the lectures, discussions with all the people, and then now I would like to thank Dr. Hani and Dr. Mustafa.
We can show just the final. Yes, we will show the final image, and then I know that we need to go. So we will inject here the final image, and then we are ready to go.
You can see here some stones are coming out on the endoscopic view.
Okay. We don't see the endoscopic view.
No, okay. There, this is ادي صبغة بقى. So now you can see the CBD.
Yes, it is.
Now you can see.
Most direction.
Good. There is. يلا inject more.
Inject
more. صبغة.
It's clear, Dr. Hani. It's very clear.
I can see that there is a small stone on the just over the. You can see it now. There is a very small stone. You see it, Hani?
Yeah, but what's important for me now is that
no stricture.
Yes.
Yeah, I think there is no evident stricture.
Yes.
We're injecting and things look fine.
Yes.
We will clean the common bile duct.
And you can sweep the common bile duct by the balloon, and it will be clear.
Yes. That's it. Yes. Okay. Thank you very much. Thank you very much.
Thank you. Thank you very much, Dr. Hani. Thank you very much, Mustafa.
Thank you.
Okay.
Thank you.
Thank you all. Now we still have around 200 with us, and there is 5 questions, Professor Khalid.
Yes.
The first one, it is, yes, it's a very simple. They said that the metallic stent should be outside the papilla, not inside. Khalid? Professor Khalid? So this is a type of stent which is used, it's used inside the common bile duct, and by this guide wire they can remove the stent. What is the name of this stent? I think the stent is present in Egypt, with available at any times. You can find it, and you can ask about it. This stent which inside. I cannot say the name of the company now, but it's present in Egypt.
Yes, Dr. Mustafa.
Yes.
I can hear you now.
Okay. They speak about this stent present in Egypt. I said yes.
Yes.
The next questions, it is how long you can keep the metallic stent, and what did you use to prove it is out with the instrument? How long you keep it?
For benign stricture,
Yes,
not more than 3 months.
but Hani left it 9 months.
Sometimes if the stricture recur back again, you can leave it for a long time.
Okay, so the second one, in case where the intraductor metallic stent placement, there are chance that the wire will go inside the bile duct, and you can do sphincterotomy in case of seam insertion. This means if the guide wire go inside.
Yes, inside the totally covered metallic stent?
No, this type of stent, the wire, it's going inside the common bile.
Yes. So
it can happen. The
Yes.
wire, what you do?
If it is covered stent, the wire cannot go.
No. In this stent, they put a small stent inside with
Yes.
the wire outside. But
Yes.
if for some reason the wire go inside, what you will
Yes.
do?
I can remove the wire again and put other wire.
No. About this stent, he go Hani and you don't see any wire, and the wire is go inside. What you will do?
Nothing to do. What's important for me for if the wire is inside or the outside? It means
No,
nothing for me.
because normally you catch the wire and you get the stent out. So at that time, you can think you can make more sphincterotomy, and you try to get the guide wire out.
I
Yes.
see.
Yes.
You have to put the guide wire outside the stent, beside the stent, and then you go by the papillotome along that wire and you make a small sphincterotomy to keep the stent clear for you.
Yes. There is another question for this patient especially. Do you follow by MRCB this patient after a while?
If I'm sure that I clean the biliary system clearly and there is no complaint from the patients, there is nothing you need to do EMRCB. But if the patients return back to gut a picture of obstructive jaundice, you have to do MRCB to be sure that there is no recurrence of the stricture again.
Yes. The last one, which I think is very important, questions, and this is 2-1. If Hani removes the stent and the stricture is still present, what you will do? You go to surgery or use restent?
No. It's better. We can use another stent, either plastic stent, multiple plastic stent, as Mustafa said in his lecture, or another self-expandable, totally covered metallic stent, and leave it for a longer time. If after 1 year, because it's known that according to the literature, after 1 year of dilatations and stenting, if there is still stricture recurred back again, there is no way except surgery. But this is after multiple trial of stenting or dilatation.
Very good. I will look quickly. Please fix the sound, the audio, bad noise, no video seen. What you hear, don't hear. Wait. There is no question now. There is some chats. What's called John Morris? I don't know who is John Morris.
I don't know him.
You know him?
No.
So he said something which is not nice, but I tried to say to him why he said that. Other things for the chats, I see the structure for an excellent presentation discussion. So all of them thank us. Another one, you always use sphincterotomy. Use sphincterotomy before metallic stent. Normally,
no, it's not.
For metallic stent, for metallic.
Sometimes we prefer to do a small sphincterotomy before keeping or inserting a metallic stent. It's better, yes.
Okay, the last one, Khaled will speak about Y stent. What is Y stent?
Y stents, it's the same technique as Hani tried to do it. It is a metallic stent actually with a wide mesh, with a wide metallic mesh. You can put the guide wire through the first metallic stent and pass to the other side of the bile duct, and then putting the another metallic stent through that wide mesh, so keeping it as a like Y-shaped. So it's known as Y-shaped metallic stent. It's metallic stent inside metallic stent, but going to the other side of the liver, to the other loop.
Okay. So I like at the end, but because all questions is nearly finished, nice job, everyone. So all the questions is finished. So I like to thank, first of all, it is Professor Khaled El-Basils, which he spent a good time with us with many good comments, very of experience, doctor doing ERCP since more than 20 years. And also is a very elegant and very straight man.
Thank you very much.
So I thank you very much for that. Then I thank also Dr. Hani Shahab for nice demonstrations of the two cases. And I like to thank also Dr. Mustafa for working with Hani and for his lectures, which give idea about many things. Before we should ask all the people behind the camera, as I said, that all the nurses or the co-worker, the radiology, the anesthesia, because I don't know who is making the anesthesia, but this is a very important man. I think he's the only man who controls the room, the nurse, the co-worker. So I like to thank all of them, because without them, we cannot do these live cases transmitted through webinar to around 200 doctors or more, which sometimes 215 around the world, many of them coming from Egypt, many coming from Tunisia, from outside all over the world. So I like to thank them, all the people. I like the people who are working beside the webinar to help this webinar to go on, all the team of ROEYA team, May, Marwan, and Heba. So I like to thank all of them because they like that. At the end, we should like the company, which is a sponsor, which is taking care of these medical educations. And I think this is one of the good things during an era. Hikma company, especially is Dr. Ahmed and Boston Scientific for supplying all the accessory. And we hope that we see you. All the questions is coming. It's very good. All of them, it's about hundreds of questions coming to us for more than 200 people, except one. I will phone him, and there are people from South Africa. He said to me, you forget South Africa, you forget some places. So I am sorry, I don't know all the people coming.
We never forget Africa, we are of them.
Yes, but I don't know the name from where, but he said to me in the chat, there is some people from South Africa. So I like to thank all of them. They're only one from 215 doctors. He gave us a questions which I don't like to mention, but I think he put another name. So I like John Morris. I like to thank you for your comment, but we will send you an email to answer your comment to us, Dr. John Morris. So thank you all. Meeting on the third wave of very soon of webinar very quickly, and thank you Khaled, thank you all the team.
Thank you very much.
Goodbye and goodbye. Bye.